This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, cardiologist at UAB St. Vincent's.
Welcome to MyHeart.net, and today we're going to talk about obesity and heart failure. And with us, we have a very distinguished guest and speaker, Michelle Kittleson. And I have to tell you that, in my days in the 80s and at UC, not at UCSF, but at Cedars-Sinai, it was Bill Parmley and Kanu Chatterjee. They were my mentor and my teachers. And of course, now in California, we have Michelle Kittleson at Cedars-Sinai, professor of medicine. We did a wonderful podcast together during the pandemic. It was for cardiomyopathy and sudden death. And we thought you were so brilliant. Everything you did was so fabulous, Michelle, that we thought we would hit you again this time, maybe to talk about heart failure. How are you doing in LA?
I'm doing great. As usual, the weather in Los Angeles is perfect. Business is good. I never complain about being busy because that's job security. And I'm delighted to be here.
100%. I have to say, we're in the Southeast here in Birmingham, Alabama. We have a beautiful sun, but it's a little chilly, which probably you don't know too much about in LA. Well, anyway, thank you, Michelle. Obviously, Michelle has been very active on the American College of Cardiology and American Heart Association. She's been on writing committees of on several topics, ranging from amyloidosis, organ transplant, heart failure with preserved ejection fraction, and then lately in obesity and heart failure. But before we dive in, Michelle, would you mind maybe explain to our patients a little bit what are we talking with the heart failure? Because now we're making they're a bit confused. Sometimes they have the impression that heart failure, your heart is weak and large, and like in the old days, used to call it heart dropsy. But now we're talking about heart failure with patients with normal heart function. What in the world?
Yeah, it's so true. And I know there's quite a push to even move away from the term heart failure because it's so dire and it doesn't necessarily reflect the experience of many patients today with incredible therapies who live very full lives. So the way I think about it is, a patient comes to you with dyspnea and edema, and of course, heart failure or a cardiomyopathy, which I think is a more accurate term, is on your differential. So if a patient comes to me with a concern for cardiomyopathy, that's really the first thing I say to them. I say, listen, you might hear the term heart failure, but I find it overly dramatic for what you may have. Let's talk about a cardiomyopathy, a disease of the heart muscle. And I say it's important first to categorize your ejection fraction, which is the squeezing power of the heart muscle, because if you have a preserved or reduced ejection fraction, that leads us to different potential underlying causes, different effective therapies, different concerns for prognosis. But I say to them, if you have heart failure or cardiomyopathy with reduced versus preserved ejection fraction, we should still be very optimistic that there are incredible therapies now to help you feel better, stay out of the hospital, live longer, and improve your outlook. So that's how I typically attack it with patients.
So basically, we're talking about patients that have problem breathing, maybe their pressures in their lungs or in their left atrium is a little increased, and they have sometimes a poor output. They feel fatigued, no energy. They can hardly do anything. And they can be due to either the heart is enlarged and weak, and measured with lower ejection fraction. And we have, as I tell my patient, it's around maybe 50 to 55%, which is normal. But when it's low, like in the 20 to 30%, that's what we call HFrEF, But with the HFpEF, we have patients with normal pump function, but elevated pressure in their lungs. They get short of breath. They can hardly exercise and do anything. Well, that sounds good. We're talking about the heart failure, and particularly when the heart is weak. And you did a wonderful article on the cardiomyopathy therapy in the last JACC issue in December. You were talking about this denicamtiv and how us cardiologists were a little jealous of the oncologists, because they have such targeted therapy. And then you discuss the approach of maybe a more personalized medicine, as some of these medications, which are known to be very helpful in some patients that have dilated heart failure where the heart is weak. And you have these activators of these proteins that help with contraction, active myosin like denacaptid. It seems to be helpful, particularly in some familial level patients with TTN cardiomyopathy, genetic abnormality, or MYH7. And I have some patients like that. So it's glad to know that we have that kind of personalized medicine. Do you think something that we're going to see more and more in the dilated and maybe in the preserved heart function? What do you think, Michelle?
That's a great point. And I'm very impressed you've done your research. Yes. I think it's very interesting, isn't it, how much we're learning about the contribution of pathogenic variants or genetic mutations to non-ischemic cardiomyopathy. So you present with a cardiomyopathy, disease of the heart muscle, typically heart failure with reduced ejection fraction. And non-ischemic, you check the angiogram or the stress test, it's normal. There, you can't blame coronary artery disease. And a 30% of those in historical cohorts were considered to have a familial cardiomyopathy. I have to wonder if it's even higher. And that's why there's the importance of taking a 3-generation family history. Sometimes these are recessive variants, and you want to try to tease out any pattern of sudden death or a cardiomyopathy, number one. And number two, it's our expanding understanding of the potential contributing variants is great. So if you test someone, you'll likely come up with something now that you didn't come up with 10 years ago. And I think it's important because number one, cascade screening of first-degree relatives, screening echocardiograms, identify other family members sooner. And also, as you note, there is an emerging world of personalized medicine where we can target these sarcomeric mutations with specific medication. So I think that study was quite preliminary, though very promising. And I think there will come a time in the next decade where instead of just impacting cascade screening of first-degree relatives, the genetic testing may offer us the promise of individualized care. It's a great time to be a cardiologist.
I agree. And that's why, Michelle, I can't retire, because it's getting more and more exciting all the time, something new coming on along the way. There was another article, in that journal that I thought was very interesting. And it's something that I'd noticed also in my practice of cardiology. So this was the report of that National Health and Nutrition Examination Survey. Very, very interesting, obviously flawed because, you don't have any data on ejection fraction, but they have a report of heart failure. And they looked at the last 35 years. From 1988 to 2023, they had over 80,000 patients that they just asked a questionnaire, periodically, and asked them if they had reports of heart failure. It's interesting that out of these 80,000, there was 3,000 that, reported to the survey that, yes, they had a diagnosis of heart failure, that their doctors told them they had heart failure. We don't know what type, but did have heart failure. So this was kind of interesting to me because obviously it was an increase. They noticed over the 35 years an increase in the prevalence of the heart failure by, over 40%. And what was interesting is they seem to attribute it to different things. But number one, that obviously our population is aging. We're surviving now these heart attacks. We have better medicine, and people are living longer, and therefore we're finding more heart failure. But also interesting to me was the shift in the risk factors in these patients. When I was kind of like starting in my practice, I was, heart failure was like someone had a heart attack. You have damage to the heart, you have an enlargement of the heart, and you end up with heart failure. What they found is now you have less history of a heart attack, you have less hypertension, you have less hypercholesterolemia because we're treating them more, with statins, so we have better treatment. However, we're finding more obesity, and we're finding more, prediabetes, which means to me that probably this heart failure that we're kind of finding more and increased prevalence is probably HFpEF. That means that, heart failure with preserved ejection fraction, even though we don't have the data, on that. But to me, even HFpEF, it seems like it has changed over the years. I used to think that HFpEF or patients with preserved ejection fraction, in my mind, it was mostly the older lady because the man had died. They had diabetes, so they had a very stiff heart, or they had kind of like some other condition like amyloidosis, or hypertensive cardiomyopathy with very thick wall. But now we're seeing mostly the obese population that is taken over as a cause of diastolic heart failure or HFpEF with a different type of pathophysiology, maybe not so much a stiff heart, but a volume expansion. I mean, these people are swollen. I mean, do you notice that also in your practice?
Yeah, no, I think it's fascinating. In fact, I was the associate editor at Jack who handled that N. Hayden's manuscript, and it was fascinating. And I think we're understanding more, as you said, the shifting comorbidities where you get good at one thing and now you have to deal with something else is cropping up. So, right, we're amazing at coronary artery disease. We're pretty good at managing hypertension and dyslipidemia. But the obesity, or what do people call now the cardio kidney metabolic axis, that has become the new goal, the new problem that is leading to an increase in heart failure. And to me, it's also very rewarding because we're so used to living in our silos. But these new advances are making us emerge from our silos, the cardiologist, the nephrologist, the endocrinologist, the internist, and try to partner together because there's so many overlapping indications for our medications, and obesity touches so many of these areas.
Well, let's talk about this phenomenon there of obesity and heart failure. I have a good friend of mine, Dr. Tim Garvey. He's an endocrinologist at UAB, and he's been in the forefront of the GLP-1, kind of receptor agonist research. And we've done, several podcasts on obesity, on the GLP-1, on diabetes. And basically, I think we discussed when obesity becomes a disease, obviously it's more than just the BMI, but usually we need a BMI of or greater than 30. But we talk about some other measures, mostly the one that is crucial, the central obesity. We talk about the waist to height ratio when it's greater than 0.5 or half. That's obviously kind of a central obesity. And we talk about obesity becomes a disease when you start having organ function that is being affected. We're talking about from the respiratory standpoint, the sleep apnea. We talk about the cardiac, the field that we're going to talk in detail today about HFpEF or heart failure with preserved ejection fraction. We talk about arthritis. We talk about metabolic unhealthiness, this metabolic syndrome where we develop sometimes a fatty liver, but they're getting to be pre-diabetic and abnormal glycemic control. So obesity and the heart failure, I mean, you've written you were head of that committee, that was, kind of published last year, again, 2025, on the obesity and heart failure. So we know that obesity it's a sensitive topic. I mean, not only for patients, but also for clinicians, as well. So from your perspective, Michelle, I mean, why is it essential that we talk about obesity and HFpEF and heart failure in a way that avoids stigma and mostly focuses on the biology and the care?
Absolutely. I think one of the most important things when you're speaking with a patient is to start by recognizing your shared mission. So I try to be very explicit about it. My only goal is to help you feel better and live longer. So we need to talk about every potential strategy to make that happen. And I'll often say to them, I would never ignore your high blood pressure. I would not ignore your high cholesterol. So I cannot ignore that you are overweight. And then often, you'll read facial cues, right? And I think clinicians are, especially with experience, are so good at reading facial expressions. And sometimes I'll see, oh, they're very uncomfortable. So then I might pause and say, if you are open to it, I'd love to discuss strategies related to being overweight or obese that will help you feel better and live longer. What do you think? And sometimes they'll be like, no, I don't want to do it. And that's okay. But if I see a wide open facial expression, tell me more, then I move on and I try to emphasize that obesity is a medical condition that we should address, just like we address high blood pressure and high cholesterol. And I'd say, it is more than just the calories you take in. It's more than the exercise you do. It is a biological condition, and it does have social, emotional, psychological overlay, but we should attack the biological condition to improve your quality of life and survival. So that's why I try to address it, because honestly, our job as clinicians ultimately is to do whatever we can to help people feel better and live longer.
Yeah. So when you talk about obesity, do you frame obesity as a risk factor? Is it a comorbidity, or is it a disease process that actually drives the heart failure?
I think it's very important for patients to understand it is a disease. I think it's very important to remove the stigma. You're not ashamed that you have high blood pressure. So I think it's very important to say it has a disease with far-reaching implications. As you just so beautifully summarized, anything from your arthritis to your sleep apnea to your heart failure, to your liver, pretty much every organ in some way is impacted by the medical condition of obesity. I try to explain that it can cause certain conditions, it can drive and worsen certain conditions. So we treat it as we would any other medical condition.
How do you link between the excess adiposity and HFpEF or heart failure? Is it, how do you explain it to your patient physiologically? Is it just a volume expansion? I mean, or is it something wrong with, the adipocyte? I mean,
Yeah, it's a great
how
question.
deep do you get?
The longer you practice medicine, the more comfortable you are with uncertainty and the more comfortable you are saying, I don't think anybody knows. That's
Yeah.
pretty much how I frame it to them. I say, we can only make conclusions by what we observe. And we can observe that patients who are overweight or obese are more likely to have heart failure with preserved ejection fraction. So your shortness of breath, your leg swelling, your fatigue, your exertional intolerance, coupled with the fact that your heart looks essentially normal in its function, systolic function, is likely driven in part by the medical condition of your obesity. And I explained, we don't know exactly why. Is it just purely related to the stress of the weight and the volume expansion? Is it related to this cardio-kidney metabolic axis with abnormal inflammatory milieu that's somehow driving it? I say, we don't have to know exactly why, but pragmatically, number one, we know the association exists. And number two, we know that managing the medical condition of obesity will help you feel better and improve your outcomes. And that's almost all we need to know. We don't really have to know why. We simply have to know that an association exists, and addressing that association can meet our goal of improving your quality of life.
A lot of times in the office, the patient, they come to see me, and I make sure that they have their echo, before. So
Yeah.
we review it together, during during the visit. And sometimes, and of course, I tell them, I said, look, I mean, the excess fat under your arm just has no consequences on you. But the visceral fat, or the fat in the organ or around the organ, whether it's in the liver, around the kidney, or around the heart, and we look at the echo, you would be amazed. I mean, sometimes in patients with BMI of 40 or 50, you look at the heart, and the heart looks compressed, with the fat around the heart, which probably has some interaction, through the adipocyte or through inflammation, but it looks like it doesn't have any room to expand that much, interestingly, for patients with severe obesity.
Yeah, and I have a feeling when you do that, just that picture, that report, that description is very powerful, right? It's a
Yeah.
powerful motivator to fix the problem. And it takes it beyond the level of how you look, right? It's
Right,
so much
right.
more important than that.
Yeah, and an image is always worth thousand
Yes.
words, Well, obesity can present also a kind of a diagnostic challenge, man, to be honest, and particularly with HFpEF. We're doing this study. It's called Maritime. You may be involved, with that as well. And it's basically in patients that have obesity and have HFpEF. And the gatekeeper is the NT-proBNP, which is a biomarker for HFpEF. We've used it, of course, for years with HFrEF in patients with reduced function. But I'm finding it so difficult, to have an NT-proBNP that is greater than 300. That's the level that we have to reach. And that is the only criteria that decide whether we can enroll them or not. And I find it so difficult because I find that in patients with larger, body mass, they have also larger muscle mass, which probably metabolize that NT-proBNP. Plus, in the South, I see a lot of African American, and which seems to have lower level of NT-proBNP as well. So, what do you do in clinical practice when you have problem validating patient symptoms with traditional biomarkers that don't really align with what they feel or how they feel?
It is. I mean, the diagnosis of HFpEF is hard to begin with, right? Because it's not like you have a gold standard. Look at my echo is abnormal. I mean, what I usually tell, honestly, trainees is when a patient presents to you with dyspnea, edema, and preserved ejection fraction, the first question you actually have to ask yourself is take a step back and say, is this even the heart? Maybe this is a kidney problem, a liver problem. Maybe it is just deconditioning that's causing some of their symptoms. And you have to take that step back because you never want to assign someone a diagnosis of heart failure who doesn't have heart failure. So how do you do it? Because as you said, the NT-proBNP is not going to be helpful. They're lower for any given level of congestion, left ventricular and diastolic pressure than they would be in a concomitant patient with HFrEF. So how do I do it? Well, I think I find very helpful, number one, the company it keeps. Meaning, do they fill that cardio-kidney metabolic milieu that really is very suggestive of the HFpEF phenotype? Are they older? It is still more common in women. Do they have an elevated BMI to support the diagnosis? Do they have hypertension, diabetes, coronary disease, kidney dysfunction? All of that supports it. And what would I be missing, or what do I not want to miss? Well, the most common masquerader or mimicker I think we don't want to forget about is, of course, amyloidosis. But that's often a very different phenotype where the hypertension is unlikely, the elevated BMI is unlikely. It happens to be more common in men. They don't typically have the diabetes CAD comorbidity. So I think it is useful to look at the demographics and comorbid conditions to help support your diagnosis. Now, it is possible, typically more on a research level, to do an exercise stress echocardiogram looking at diastology, or an exercise right heart catheterization to look at increases in filling pressures. I don't typically go to that extreme in measure. What I will do is, you smell like HFpEF. Your H2F PEF score is suggestive, and that really encompasses readily available, clinically accessible variables that are consistent, like hypertension, elevated right ventricular systolic pressure, older age, elevated BMI. So it fits that same milieu. And I say, let's start you empirically on therapies that should help improve your shortness of breath. So, because I feel in that person, the SGLT2 inhibitor plus minus the mineralocorticoid antagonist are probably going to be useful anyway, because they have probably hypertension, diabetes, and so for those comorbidities. So instead of delving into the more research type exercise, echo or right heart cath, I will take a more pragmatic approach. Let's put you on the therapies and see what happens.
Yeah. I'm a bit frustrated with that NT-proBNP, and I think it's we're going to have to revise and find a better kind of a biomarker.
Yes.
I think of that. And it could be that we have to do, some kind of like testing, like HFpRS, for example, to look at polygenic risk, whether that would be a better predictor of who's going to develop heart failure. I mean, just last week, I did an arteriogram of someone who weighed about 300 pounds and very short of breath, normal coronary arteries, and end diastolic pressure of like 20, and a totally normal NT-proBNP.
Yeah, that's what I mean. It's
totally normal.
I find it very, very, as you said, unsatisfying and frustrating that you cannot hang your hat on a normal NT-proBNP in someone who has overweight or obesity.
Right. Let's talk about management strategies. Let's start, we'll go from lifestyle to medication, but let's start with the number one, which a lot of us call, this HFpEF is the exercise deficiency syndrome.
Yes. Yeah, I know there's been so many beautiful studies to illustrate that if one can exercise, now sadly cardiac rehab is not covered for HFpEF, which is I think a greatly unfair, as there is evidence to illustrate that if you have HFpEF and you can engage in a supervised exercise training program, that you will improve your feel and function, i.e., you will improve your quality of life scores, and you will improve your maximal oxygen consumption objectively measure of cardiovascular fitness on a cardiopulmonary exercise stress test. So there's no question that exercise is hard, but exercise helps. What I like to tell patients is it's not your fault that you're short of breath when you exercise. It's not your lack of will. It's not a medical mystery that you're short of breath when you exercise. Your heart is stiff. So when you exercise, boom, those pressures go up in your heart and lungs, and that makes you short of breath. I said, it's not dangerous that you feel that way. You're not harming yourself. So don't worry. But it's not that if you just tried harder, this would go away. I said, it will take time and sustained effort. And I'm sorry I can't give you cardiac rehab, but just figuring out how far you can walk until you get short of breath. And then every week or so, try to walk another minute. I mean, it has to be as simple as that. And I tell them you should take heart that you won't feel better today or tomorrow, but of months of sustained effort, you can improve your quality of life and your overall cardiovascular fitness.
Yeah, no doubt about that. Also, I tell them to do a little bit of resistance training. I recommend them 3 times a week, doing bands or light weights, because I tell them this probably will help you a little bit more about losing some weight.
Yeah.
And the aerobic exercise, the walking, mostly the walking, will help you maintain it, and increase, the level that you can do. Well, let's talk about medication, because the medications have been the GLP-1 have just revolutionized, I think, our field, and have had the type of impact so far, probably even greater than statin. And we're just at the beginning of it. I think that field is exploding. But particularly in the HFpEF, we've had 2 significant trials. Number one was STEP-HFpEF, and the other one was Summit. The first one with semaglutide or Wegovy, and the other one with tirzepatide or Zepbound. How significant is that, in our clinical practice?
Yeah, it's a good question. So let's start with STEP-HFpEF. So individuals with HFpEF and an elevated BMI were enrolled to receive semaglutide versus placebo for a year, the primary endpoint being a change in 6-minute walk, or the primary endpoint was body weight and KCCQ, or quality of life, but they also looked at change in 6-minute walk. And it's no surprise. And the average BMI is 37. So these were obese, limited patients. And it is no surprise that patients were able to lose weight, lost about 10% of their body weight, and in doing so, felt better and walked farther. So STEP-HFpEF was an important trial because it illustrated, number one, that semaglutide was safe, because there had been earlier reports in patients with diabetes and reduced ejection fraction that other medicines like exenatide and liraglutide might increase the risk of atrial arrhythmia. So there was some concern. So clearly safe. And second, that effective in weight loss. So after STEP-HFpEF came out, the million-dollar question was, well, did they just feel better because they lost weight, or is there and there's really not very many other effective ways to lose weight, or is it doing something good, particularly to the heart? And I think that's where the Summit trial came in. So the Summit trial could, again, patients with symptomatic HFpEF, elevated BMI, now use tirzepatide versus placebo. Now, I think this was an important trial because they kind of pivoted in the middle of enrollment because STEP-HFpEF came out, and they said, oh, this medicine's good for HFpEF. Let's have a clinical endpoint. We already have a KCCQ, a 6-minute walk. Let's add on a clinical endpoint. Let's add on time to composite worsening heart failure, cardiovascular death. And in fact, the trial was a success. Patients lost weight. As expected, they lost more weight because it's a dual receptor agonist, lost about 12% of body weight as opposed to maybe 10. And they felt better, they walked farther, and there was a reduction in clinical events. So if you took the sound bite of the SUMMIT trial, you'd say effective in clinical events in patients with obesity and HFpEF. But I think you have to dive a little deeper into the fine print. There were very few clinical events. There was 29 versus 52 of the 700 something patients enrolled. And that's because they really wasn't initially powered to look at clinical endpoints. They kind of pivoted midway because of their excitement. So I don't think it answers the question adequately. We can say both agents are safe in HFpEF. They will not cause cardiac events. We can say both agents are effective in weight loss. But can we say that there is a true benefit for clinical cardiovascular events? I think the numbers are too small to say for sure. And that is why I suspect, I don't have any role in this process, but I suspect that the FDA hasn't extended the indication of either agent to include those with heart failure. That being said, as clinicians, I think we can still feel very empowered to give these medications, because just because there isn't a heart failure indication doesn't mean that your patients aren't going to meet one of the other many indications, which is obesity or overweight with a weight-related comorbidities. And so many of those are so prevalent in HFpEF. So I think the trials are exciting, but not necessarily in that they confirm what we suspected, safe and effective for weight loss, but it would be an extrapolation, an overreach to say they're really going to intrinsically improve heart failure.
So for you, it's enough of an impetus to prescribe it to your patient, right, in the clinic?
Yes, absolutely. Absolutely. I think, while we can't confidently conclude that heart failure events are better, we can confidently conclude that symptoms and functional capacity are improved. And that's a very important goal for our patients. What's our mission as clinicians? Feel better, live longer. You're definitely not going to live shorter. I don't know if you're going to live longer with these specifically for your HFpEF, but you will lose weight, you will feel better, and your weight-related comorbidities will improve. So I do think there is absolutely a role for these agents in patients who meet one of the standard FDA indications of overweight with a weight-related comorbidity.
And we're talking about not only lowering the weight, but lowering the lipid, lowering the blood pressure, lowering inflammation with improvement in CRP. So it is really kind of and lowering, of course, of the A1C or the glucose. But as we know, the access to obesity treatment is uneven. Have some patients that just can't afford it. I mean, we try to, kind of fight the insurance, the prior authorization, and despite the fact we have good data, we have good reason, to give it to them with studies that really show benefit. We're kind of ending against the brick wall. How should we advocate for our patient? What could clinicians do? I mean, do you recommend or do you use sometimes the compound that we can find around maybe at a lower cost, like the compound tirzepatide or things like that? I don't like it because it's not FDA, regulated, but is it better than nothing?
Yeah, it's such a good question. I guess there's two ways we can think about advocacy, and one is every patient that sits in front of you in clinic, and then on a larger level. When it comes to a larger level, I think places like the American College of Cardiology is really dedicated to advocacy on that larger level. So being part of your ACC community, I think, is a huge way to affect more change on a larger level. But for the patient sitting in front of you in clinic, it is so frustrating when a medication has an FDA-approved indication that there are games that are played with the insurance company that they just think if they put up enough hurdles, you'll give up. And it is very frustrating. I have to say, for a plug for AI, these AI bots are really lovely at writing appeal letters. So I think it never hurts to work smarter, not harder, and use that at your disposal. I am very nervous about the compounded agents. I think pharmacists are the heroes of the healthcare system. I feel very blessed when I do my heart transplant work. We have a pharmacist that rounds with us every day in the hospital, and it's like she saves a life every day. And I've asked them about the compounded agents, the pharmacists I work most closely with, and they are so worried about them. I think it does come down a little bit to perfect is the enemy of good. And is it wrong to feel so that you need the perfect FDA approved, it's good, compounded, good enough? It makes me nervous enough that I've advised against it, but I think some patients don't take my advice, and that's okay, and have gone that route. But I'm hopeful that with ongoing advocacy on a larger level and more studies, that this barrier to insurance coverage will improve.
Yeah, I hope so too. Looking ahead to the future, Michelle, there's many unanswered questions. Of course, we don't know, is there kind of a weight threshold? What's the right amount of weight loss needed to benefit patients with HFpEF? What's the proposed mechanism? I mean, Milton Packard talks a lot about these different adipocytes. I mean, that's a field in its own, by itself. Should obesity targeted therapy become the standard of care in the future with HFpEF?
Yeah. I think there are so many unanswered questions, and there's so many things I think we also need to understand are what are the tips and the tricks and the pearls to promote better tolerance and adherence. Because if you look at real world analyses, not the clinical trial dropout rate or discontinuation rate, but the real world analyses and registries, you see that it can be anywhere from 30 to 50% of patients do stop due to intolerance or side effects. So I think a better understanding of what are those tips and tricks, if it's start low and go slow and space it out and smaller meals, and then two, we worry about the muscle loss that can occur. And we worry about sarcopenic obesity, where you're losing muscle as you gain fat, and as you lose fat, you're losing muscle. So whether there's a way to employ the resistance training. I think, we don't want to be siloed in medicine. We don't want to be hyper specialized. We want to be able to take care of as many patients as we can. But a cardiometabolic clinic, I think, would be a wonderful way to make sure all of these intersecting comorbidities are optimally managed. And I think, in a way, an expectation at these clinics would be that obesity is a medical condition, and it sort of destigmatizes it. So I sort of envision a future when all of our large healthcare systems, you have a clinic where you have cardiologists and nephrologists and endocrinologists who are kind of working together to streamline care and optimization of these cardiac risk factors, so that, I don't know, 30, 40 years from now, they'll say, remember when coronary artery disease was bad? And then remember when HFpEF was bad? I don't know what'll take over next. But I feel like that's the future, because part of it is the incredible science of all these new agents, triple agonists, quadruple, who knows what else is out there, but also the implementation. And I think that's going to be such an important key.
Right. Well, thank you very much, Michelle. I think with all this, I think we got rid of the obesity paradox.
Yes.
Right?
Yes.
I mean, there was so much flaws into this statement because of the patients with sarcopenia that you discuss about, and there was BMIs of 18 or below that skewed, basically our observation. But I think it's exciting to see, how many new medications are becoming available, and how much research is being done in that field. You've mentioned the triple Gs, where patients lose 20 to 30% of their body weight. I mean, of course, that's almost as good as bariatric surgery, It's pretty incredible, which is, again, the gold standard. Michelle, thank you very much for your insight into your clinical practice. And I think you've obviously published some beautiful scientific statement with the American College and the American Heart. And now I think it's important to make sure that it gets implemented, in the clinic, and hopefully that it's just not kind of a good read, but something that could really kind of direct our patients, in the right direction and the right treatment. So thank you for what you're doing, Michelle. Hopefully we
Amazing.
can do that.
Thank you for the opportunity. It was fun.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.